Welcome to the AAMDSIF COVID-19 update on vaccinations for bone marrow failure patients. Thank you for joining us. My name is Alice Hauk, Senior Director of Health Professional Programs, and I'm introducing today's webinar. My colleague Lee Clark, our patient educator, will be moderating the questions and answers. As we get started, we recognize the generosity of Bristol-Myers Squibb and Acceleron for special support of our COVID-19 educational programs. We also acknowledge Bristol-Myers Squibb, Alexion Pharmaceuticals, Jazz Pharmaceuticals, Apellis, Agios, Taiho, Genentech, and Takeda for their financial support for our 2021 webinar programming and the generous support of patients, families, and caregivers like you. With so many webinars, meetings, and conferences online, it's possible that you may lose your connection. If that happens, please refer to the confirmation email and try the link again, or use the call-in number and passcode provided. We are also recording today's webinar, and it will be available on our website in 2 to 3 business days. You will be notified by email when it is ready for viewing. You are welcome to ask questions at any time during the panel discussion using the Q&A window at the bottom of your Zoom screen. Type your full question into the small text box window and press enter. Our panelists will do their best to respond to all questions. When submitting your questions, please submit your entire question at one time, and please do not share any private health information. Our presenters cannot answer specific questions related to your health. Today's presenters are Dr. Amy DeZern, Director of the Bone Marrow Failure and MDS Program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, and Associate Professor of Oncology and Medicine at the Johns Hopkins University School of Medicine. Dr. DeZern is board certified in internal medicine and hematology oncology, and she is a member of the AAMDSIF Medical Advisory Board. Dr. Veronica Dioverti is Clinical Associate in the Division of Infectious Diseases at Johns Hopkins University School of Medicine, where she focuses on caring for transplant, hematology oncology, and other immunocompromised patients. Dr. Dioverti is board certified in internal medicine and infectious disease. Welcome, Dr. DeZern and Dr. Dioverti. Dr. DeZern, I'll turn it over to you to begin the discussion.
Hi, everyone. We're so glad you joined us today. Thanks for giving up part of this, at least here, rainy Thursday afternoon to answer some questions about a very timely and important topic. We actually have some, I'll let Dr. Dioverti say hi, and then we have a couple slides we can go through, and then we can get right down to your questions.
Hello, everyone. Thank you so much for joining today, and I'm happy that we get the chance to discuss this very important topic with all of you. And yes, indeed, it's a very rainy, gray day today here.
Let's see. Would you be able to advance the slides? So we'll just, Veronica, you want to go through these really quickly?
Absolutely. So we are still continuing to recommend everyone to keep doing the safe measures in this time of COVID. It's not over. And so we need to keep wearing the masks anytime you're outside your house. Very important to keep washing your hands, just soap and water, 20 seconds, dry them off. When you dry them, if you're not in your home, try to use paper towels to shut down the faucet afterwards. If at all possible, you need to stay at home. Don't go anywhere where there's going to be large crowds, particularly with people that are not going to be respecting COVID safety measures. And then, as we'll talk today a little bit more, it's very important to start the discussion about getting COVID vaccination with your hematology oncologist. And we'll review this a little bit more in a sec. All right, so I first wanted to show everyone the types of vaccine that we now have available, since we get questions all the time whether it's safe for people to get this vaccine. So this is just a quick overview of all the kinds of vaccines that we have. So We all know about the inactivated vaccines where the virus is actually dead. That applies for most of the vaccines that we've had so far. For other non-COVID vaccine, then we have the live attenuated vaccines where the virus is actually there, but we treat it so that it's weakened and unable to cause an infection. The biggest example of this is the measles, mumps, and rubella vaccine, or MMR vaccine, which is a live virus vaccine. We have recombinant protein. So these are protein particles from a virus. So it doesn't use the whole virus as the other two. The biggest example of that one is the hepatitis B virus that we all get. Then we have vector vaccines. What this is we grab a different virus. It's usually adenovirus, which causes cold. And then that virus, we attach proteins from other viruses so that that virus can then go into your system. It's unable to cause an infection, and that virus is going to sort of carry the proteins from the virus that we want to vaccinate against so that it elicits your body defenses to produce good antibodies against whatever we're targeting. So those are the vector-borne vaccine, the vector vaccines. We then have the newest technology in vaccination, which are the DNA and RNA vaccines. We know that the coronavirus is an RNA virus. So the DNA vaccines and the RNA vaccines actually uses genetic material from the virus. So I'm going to focus mostly on the RNA vaccines because so far we don't have any DNA vaccines. The RNA vaccine is the one that we're now currently using in the US. It's a new technology. So what it is it grabs genetic material from the virus. And in this particular case, it's called messenger RNA. We call it messenger RNA because it actually carries a message. So that little messenger RNA goes into your cells, but it's very important to know that it does not go into where your genetic material is stored in your cells. So we have the cell, and then inside that there's an area called nucleus, and that little area is the one that contains our genetic material, which is called DNA. So this messenger RNA goes nowhere near our DNA, because I know that a lot of people are concerned that this messenger RNA is actually going to attach to your DNA and cause alterations. That's not possible. So what it does is it goes into your cells. It carries this message to produce a protein from the COVID virus. And then once it delivers that message, it dies, it goes away. So all you have is a little protein from the virus that then attaches to the surface of your cells, and it makes your body defenses react against that protein and make great antibodies against COVID, okay? So very safe vaccine despite all what we're hearing around. It does have side effects, but it does not alter your genetic material. So that's very important to keep in mind. Now, in terms of the three vaccines that we have in the US, the Pfizer-BioNTech and the Moderna vaccines, both of them use messenger RNA technology. The Janssen vaccine, or the Johnson & Johnson vaccine, is a vector vaccine. So the vector is adenovirus, dead virus, unable to replicate in your body, unable to cause any infection, but it carries a protein from COVID and thereby elicits a great immune response. So of the three that we have here, the Pfizer-BioNTech and the Moderna vaccine are actually 2 doses. The Pfizer-BioNTech is given 21 days apart, and then the Moderna 28 days apart. So a little bit of a difference there. The Janssen or Johnson & Johnson vaccine is a single dose vaccine, different from the other 2. Now, I know everybody's thinking, oh, well, and then we have the other vaccines. Of the other ones, I'm sure everybody's heard a lot of on the news about the AstraZeneca vaccine, that it's being used mostly in Europe, and a lot of countries have banned vaccinating because of this issue of clotting disorders, or thromboembolism is what we call it. And so they've been using it in the UK too. They haven't come out to give any specific recommendations, but they're still using it. The other one that's being used throughout Europe and Asia too is the Sputnik 5 vaccine or Sputnik V vaccine, which is a Russian vaccine. It's also a vector-borne vaccine. It's actually turned out to be pretty good. So of the ones that we have in the US, one very important question that I get asked all the time is about its efficacy. Now, the one thing to keep in mind is that the way these companies have constructed the clinical trials for the vaccine and the way they report the results is a little different. So it makes it a little harder to compare them side by side. I can tell you that the Pfizer-BioNTech and the Moderna vaccine both reported the results in a very similar way, so we can compare them head to head. The Pfizer-BioNTech vaccine, actually, it's 95% effective in preventing symptomatic COVID. And the Moderna vaccine reported the results in the same way, and it turned out to be 94.1%, which is equivalent. So they're both really, really good vaccines. And in fact, we were just hoping to get a vaccine that was 50% efficacious. So I guess we hit a home run on this ones. So we're pretty excited. The Janssen Johnson & Johnson vaccine reported their results in a very different way. So we can't necessarily compare them in terms of efficacy unless they publish the results in a different way. But it's 76% effective in preventing severe COVID. So that's the way they report the results, and that's the way we have it. Now, at this point in time, I would say whatever vaccine you can get a hold of, you should get it. They're all really good. They will all protect you against COVID. Once we get to the point that we have vaccines for everyone, then we could get a little picky and choose what vaccine we want to get. But at this point in time, everybody should get whatever they can get a hold of. And then we can move to the next slide, please. All right, so I just seeing people every single day and getting the same questions every day. I just kind of put through some of the questions that I get most frequently. What do I do if I miss a dose of the vaccine? So we talked about the fact that both the Pfizer-BioNTech and the Moderna vaccine have to be given 2 doses, right? So if you got the first dose and for whatever reason you missed the second dose, you can get it later. Up to 6 weeks later or 42 days is what we say, but as soon as you can, okay? If you need another non-COVID vaccine, but for whatever reason you already got your COVID vaccine, you need to space those vaccines out for at least 14 days. So no vaccinations that are non-COVID should be given within that time frame from your COVID vaccine. So make sure you plan ahead because you will need the 2 doses, right? And so there's a potential long period of time, or at least 8 weeks, that you won't be able to get any other vaccines.
I'm just interrupting really quick to highlight for our post-transplant patients, because certainly our post-transplant immunization series is set from the day 0 of transplant. For some of the patients, this may be relevant. And as a transplanter, I'm becoming quite accustomed, as are my nurses, to moving the transplant vaccinations. That is okay. We want to prioritize the COVID vaccination because the timelines are a little bit more set. And we can certainly move your scheduled 6 months ago post-transplant immunizations back 2 weeks if we need to, or more depending on the timing. So just make sure you let us know and we're happy to accommodate.
That's very important. Thank you for that. Absolutely. So the COVID vaccine takes preference over any other of the vaccines that you'll be getting for sure. Now, a huge question too, do we need to check our antibody titers after we get vaccinated? The answer to that in general is no. And there are a couple reasons for this. First of all, even if we were to check your vaccine titers, we don't know what number will tell us that you're absolutely protected. So that's first issue. Second issue, if you responded to the vaccine, regardless of whether you responded or not, you still need to make sure you follow the same precautions and safety against COVID. So you still need to wear your mask, you still need to keep social distancing, you still need to wash your hands all the time, and also avoid large crowds. So that's regardless of whether you're vaccinated or not. And so that's mostly the reason why, to this point, we're not recommending checking post-vaccine titers, okay? A question that came up recently is, okay, so I had COVID, I got my first dose of vaccine, couple of days, weeks later, I had COVID, what do I do now? So in that situation, we would ask you to wait until you're completely symptom-free from COVID, and then you can move on to get your second dose. You can push it out a couple months, that's totally fine, but that second dose is gonna boost up your immune system so much more after the infection. That's still really important to get it. If you had COVID before the first dose of the vaccine, you still need to get the 2 doses of vaccine. So also very important. You will get protection from the infection itself for sure, but that vaccine is going to really boost up your immune system. So important to get the 2 doses. And then there are people that had COVID and then they were treated with monoclonal antibodies. So the Regeneron cocktail is the one that most of you are probably familiar with. Or convalescent plasma is the other treatment that we give for COVID. Because those 2 have COVID antibodies, there's the concern that they may bind to whatever response you get from the vaccine, and it's going to make it ineffective. And so it's very important to wait at least 90 days after you get any of those 2 therapies in order to get vaccinated. So that's the caveat if you had COVID. So if you had COVID, got treated with any of those 2, either monoclonal antibodies or convalescent plasma, you need to wait 90 days. If you had COVID, did not get any of those treatments and recover from COVID, then you can go ahead and get vaccinated anytime. All right, and I think those are my 2 slides.
That was wonderful. And I think we've had a lot of questions coming in. Lee, were you going to read them out, or how did you?
Absolutely. Thank you so much. We have quite a few questions that have come in. Our first question is, what is the effectiveness of the COVID-19 vaccine for transplant patients currently on immunosuppressants, such as tacrolimus?
I'll let you go first, Veronica.
Okay. We honestly don't have any information as of yet. So we first came out with the efficacy of those vaccines in healthy people, and that's who we start vaccinated. There are a number of centers that are starting to get some data in terms of efficacy. We don't have anything out yet, but regardless of the efficacy, we still need to get vaccinated.
Thank you. Does the dose amount alter the effectiveness of the vaccine?
So this is again an area where we have a little bit less data, and depending on whether your transplant was for aplastic anemia or MDS, there may be ways to modulate your current tacrolimus dose depending on if there's active GVHD or not. And I really think the bottom line is you should probably get it, but talking to your transplant physician about where you are in your post-transplant immunosuppressive course is worthwhile, because I've had some people that instead of running the tacro level from 10 to 15, I feel very comfortable with their clinical course running it from 5 to 10 or a little on the low side.
Thank you.
And I'm just going to add a little bit on that different population, but on our solid organ transplant patients, so kidney, lungs, heart, and whatnot, they are usually lifelong on prednisone, tacrolimus, and CellCept, or mycophenolate, I should say, which some of you might be familiar. We do have some data on that side already, and it seems that those that are on prednisone and tacrolimus will respond to the vaccine fine too. So I'm guessing it's going to be the same for our transplant patients, but again, we don't have any data yet.
Thank you. Is there a national center that is collecting data about COVID and transplant patients?
The answer is sort of. Not exactly, but there is a National Cancer Institute initiative that at NCC and comprehensive cancer centers, which include high volume transplant centers, that there's the capacity to register in this kind of registry type study. It was really quite candidly designed for solid tumor cancer patients. And Veronica, you can comment on some of the more single center initiatives if you like.
Yeah, so that there are many centers that are gathering data on their own. I don't think there's a national effort to gather data on our hematology, oncology, and bone marrow transplant patients just yet. There's a big center in Seattle that's gathering data for sure. New York and Texas are the other two, and we are starting to do the same thing here, but there's no unified database yet.
Thank you. This question is in relation to retail pharmacies are refusing to give COVID shots to transfusion-dependent individuals. Are you aware of this, and do you have any suggestions?
I'm very aware, as all my patients are transfusion dependent if they're pre-transplant, and I have a little letter that I send with them on my letterhead. I suggest you ask your treating physician or whoever prescribes your transfusions, and it just says that I am taking care of so-and-so and am aware of their blood dependency, but believe they are appropriate to be vaccinated. Please proceed. Some language like that.
Thank you. This question comes from a patient who's had their second dose.
Congratulations.
On February 23rd, and they'd like to know how long will it be effective?
Well,
Oh,
we don't know, but
that's the short answer. Yeah.
you definitely are safe now.
Thank you. If a person is vaccinated with both shots, is it safe for them to go out into the grocery store on off hours wearing a double mask?
I think so.
Agreed. As long as you're keeping all those precautions that we talked about.
Thank you. The next question is, if there are no side effects with having both COVID doses, does that mean the vaccine is less effective?
No, I wouldn't read it that way. There are just some people who respond differently to all medicines with more dramatic, side effects that are felt in others. But I don't, to my knowledge, that would not correlate with lack of effectiveness.
Thank you. Are you aware of any efforts or timing to produce a booster shot for immunocompromised individuals?
To my knowledge, everyone is so focused on getting the first doses into individual patients. That type of question, which is very valid both clinically and academically and research-wise, is a bit on the back burner right now. Do you know anything else, Veronica?
No, not really. I mean, we have had a lot of discussions about, and I'm sure everybody's thinking about this different strains that are coming out of South Africa and UK and Brazil. We don't know if the mutations that we're seeing are enough that we will have to eventually develop newer versions of the vaccines, much like we do with the flu. So far, the UK strain seems to be very well covered. So is the South African. We still don't know about the Brazil strain.
Thank you. Given the recent reports indicating a rare reaction in the drop in platelets in some patients, how should aplastic anemia patients with low platelet levels proceed regarding the vaccine?
I think this is a very valid question, and I actually had commented to my colleagues here that New York Times article has really been a little bit of a thorn in my side, if I'm candid. It's always appropriate to be concerned about side effects, and quite practically, this is an intramuscular injection, and patients with profound thrombocytopenia should really get it after a platelet transfusion if they're truly having single-digit platelets, just to prevent a hematoma. But in terms of the ITP that is a very different type of immune-mediated thrombocytopenia, quite separate pathophysiology from aplastic anemia. I really think that is a truly idiosyncratic, rare reaction that you should not feel that just because you at baseline have aplastic anemia or even thrombocytopenia from MDS would be subject to be more likely to have that reaction. That is my medical opinion, and lots of hematology colleagues have talked about the platelet issue and feel similarly.
Thank you. Our next question is, which vaccine do you recommend given the different efficiencies and timing of testing due to the virus variants?
Go ahead, Veronica.
Just get whatever you can get your hands on. Seriously, whatever you have at hands. All 3 vaccines available in the US are actually very effective. So whatever you can get your hands on, don't be picky, just get it. When we have more vaccine supply, then we can talk about choosing and picking one versus the other, but whatever you can get as soon as possible, go ahead and get it.
And I just want to highlight, it responds to another question, but also something that you had said in the beginning, Dr. Dioverti. Yes, it seems like just if you quote percentages that somehow Johnson & Johnson or Janssen is less effective, but really it's exceptionally comparable in terms of severe COVID and death prevention. And certainly we don't want anyone to get COVID, but those are the complications that we really do not want to have. And I feel medically very comfortable that all 3 protect at quite similar rates against those things, the severe COVID and death. And so that's why we're very comfortable saying, get what you can get.
And I just, to that point too, I mentioned earlier, so we said that the Pfizer-BioNTech is 95% effectiveness, Moderna has 94.1%, both very effective. But again, the way they reported the Johnson & Johnson's or Janssen vaccine efficacy was very different from the other 2. So they reported the 66.9% or 67% as protective for severe COVID, whereas the other 2 is effective against all symptomatic COVID. So the way they reported is different. That's why we're thinking, oh, the Janssen is less effective, when it's not really true. They're all protective against severe COVID.
Thank you. The vaccines are new technology. Any concerns for triggering an immune response for somebody who has very severe aplastic anemia?
Not really. Your point is well taken that new things are new, but certainly large quantities of people, both on the trials and even now in practice, have been vaccinated, and we are not seeing any common immune triggers.
Thank you. How bad do you think side effects could be with the second Moderna shot? I get terrible side effects from anything, plus with MDS and having fibromyalgia. What do I need to look at in possibility of side effects?
I think in all honesty, I ask every patient of mine, just so I'm learning, and my friends too, to see how they've responded. The second shot does seem to be a bit worse than the first in terms of how somebody feels after they got it. Not in everybody, but it may just be necessary to take a day where you truly rest, hydrate really well, lays around on the couch or the bed or where it's comfortable, and it's quite okay to feel less than ideal after the second shot. I don't think that correlates with any dangerous medical conditions, but if you're not feeling well 48, 72 hours after the shot, it probably really is time to call your doctor, probably your MDS doctor, your oncologist, and say, I'm just not myself, and see if some laboratory evaluations or even exam might be prudent. Is there anything else you're seeing from the ID perspective?
No, I've seen anywhere from I had nothing with the first shot, I was like very tired after the second, to people that took it well both doses. But it's very, very common to see fever, chills, diffuse body aches, people are extremely tired, nausea, vomiting, diarrhea, really anything. But again, if it goes beyond 72 hours, then I would definitely bring it up.
Thank you. In Canada, doses are being delayed up to 4 months due to supply. What challenges does this present to someone who is immunocompromised, and will this lower the efficiency of the vaccine?
I think it's complicated. The short answer is I'm not sure that that overtly affects an immunocompromised person differently than it does the entire population, because herd immunity and percentage of people who are meaningfully vaccinated is going to be less. It's a tough situation, and I'm not sure that there's anything we can do to change it. This is certainly known in Canada. I have a few Canadian patients, and I know it's been a challenge, and so I'm sorry for that.
Do people who have been diagnosed with low-risk MDS and have now been vaccinated with both vaccines need to take any different precautions other than the general public? Do they need to do anything differently?
Not really, but remember Dr. Dioverti's list. We're still wearing masks, we're still washing our hands, we're still avoiding those crowds, but so is the general public. So that is how I would characterize that clinical scenario as well.
Thank you. Are there any timing concerns for getting the vaccine if you get monthly IVIG infusions or ECP treatments?
This is a complicated question. I quite often call my infectious disease colleague. I do. I have several patients like this.
Oh, and actually, it's funny that you mentioned that because we just had a meeting about this very same issue earlier today. So generally, the people who are getting IVIG are the ones that are not necessarily responding to any kind of vaccine. There's a reason why we're giving it to them. And I have to apologize. They decided to test the fire alarms for some reason here. So I'm hoping they'll be done soon. But in any event, so it's a tough question. I would advise probably to discuss with an immunologist for sure. If you're getting IVIG, then I would say that you probably won't benefit from the vaccine all that much, but we don't know that. So we are still vaccinating some of our patients regardless. But that's a discussion that needs to happen between your oncologist, immunologist, and yourself.
And the ECP plays into the discussion quite a bit as well.
Right.
And it may be ultimately that this is an example of a specific clinical scenario where it may make sense to wait until the ECP is done.
Thank you. This question comes from a patient who watched a seminar on vaccines. They had a printout of who should not receive the vaccine. One group was blood cancers. They said it destroys red blood cells. Was there testing done on blood cancer patients?
No patients like my patients and many of you who I love dearly were in the clinical trials. So the short answer is no. This is a very common notation on these printouts that keep appearing in my office. But I think in the lab, you can get red cells to hemolyze with almost anything because they're quite fragile in the test tube. But I have vaccinated a lot of my blood cancer patients without any change in their hemoglobin.
Thank you. In Canada, individuals will most likely be vaccinated with AstraZeneca. Is there any available data on recommendations for MDS patients to receive this vaccine?
Not that I'm aware of. I know that there are certainly people who have, I think, quite understandable concern about the thrombotic risk. And it's not an easy question because the thrombotic risk is present with COVID as well. And this has to do with complement and a wide variety of other sort of complicated coagulation cascade pathways. But I do still believe that if that is what you have access to, that the AstraZeneca vaccine is a good one.
Thank you. Are there additional concerns for ITP patients who already have low platelets due to AA receiving the vaccine?
if I understand the question correctly, that the baseline disorder is aplastic anemia, not ITP.
Yes.
Hopefully I'm understanding that.
Yes.
So again, this is what I was mentioning before, that the mechanism of thrombocytopenia in ITP is quite distinct from that in aplastic anemia. And I do not believe we should assume that just because you have low platelets for another reason that you would be more prone to ITP. I don't think that's true.
Thank you. This question comes from a PNH patient who is taking Soliris. They would like to know is the vaccine going to work with them, for them, and should there be any concern about getting the vaccine in between their infusions?
This is an interesting question, and I can tell you actually at Hopkins, there's a lot of very interesting research that's ongoing without results, but about complement activity and blockade in the setting of COVID in general, as well as COVID vaccination. And in the interest of somebody who's getting Q14-day eculizumab, we don't really have a reason to think that somebody would not respond to the vaccine. Whether or not it precipitates additional activation of the alternative pathway of complement is a little bit of a complicated question on the research range. And this is my lengthy way of saying you may want to get it closer, if you can, to when you just got your Soliris dose. And I have a couple patients in whom I have checked their LDH sooner than the 14 days to see if they're starting to hemolyze more quickly. And that's really about having a very open conversation with your physician and making sure that if there's a change prior to your 14-day next dose, that you let them know. I have not seen much uptick in hemolysis, but it's a theoretical risk.
Thank you. Do we have any data for aplastic anemia patients that the vaccine has caused relapse?
There's no data that I'm aware of. I've done enough patients and know enough patients that I have not heard of any.
Thank you. This question reads, this is regarding to the data for aplastic anemia patients, and it says, how is it not a risk in getting the vaccine when it trains the T cells? Why risk messing with these stubborn T cells if a patient is responding to treatment? How does this not risk a relapse for a non-transplant patient?
So I understand your question very well. And yes, it is true that there are alloreactive T cells which were the pathophysiologic cause of the stem cell attack that caused the low counts in aplastic anemia. But I'm gonna let Dr. Dioverti remind you of how these vaccines exactly work, which is why we don't think it's that risk that you're asking about.
Yeah, so these vaccines actually trigger an antibody response. So your antibody response is going to be mostly through your B cells, not necessarily through your T cells. Although it does activate your T cells as well as other cell lines too, what it really does is it triggers a very, very specific response to that particular protein from that particular virus. And so although there is some concern, it hasn't been proven, and in theory, it shouldn't be a problem.
And just to reiterate, because I heard her say it too, that there may be a T cell response, but there's really no reason to think it would be the T cells that caused the aplastic anemia, those very specific alloreactive T cells against the CD34 positive stem cell. There's no reason biologically that those should be disproportionately activated in a clinically harmful way to you.
Thank you. Are there any circumstances in which you would not recommend patients get the vaccine?
I'll let the ID expert answer first, and then I'll mention a couple of my patients.
If you have another acute infection, that's a big no. Your to say this in a very simple way, your body defenses will be distracted. They will not respond as well as they should. So that's situation number one. Situation number two, there are certain immunosuppressive therapies that we use in some specific cases. Like, for example, rituximab is the biggest one, where that may actually impair your ability to respond to the vaccine. And so that needs to be spaced out too. So the biggest two considerations from my standpoint would be make sure you're not having an acute infection. And the second one, we need to review what kind of immunotherapy you're getting to see if it's going to affect in some way your vaccine response, to make it so that we would need to delay either the vaccine or the treatment if it's safe to do so.
And if you're a patient with significant graft versus host disease on high doses of steroids and possibly Jakafi or ruxolitinib, or with a really significant CMV infection post-transplant, those are patients we have not been doing it in.
Thank you. This comes from a patient who says, I had typical side effects almost 3 weeks after my second shot. Is that possible? These side effects lasted about 24 hours.
3 weeks sounds a little long to me. You know what you feel, certainly, but I'm not sure that it would have still been related.
Thank you. Are any of these vaccines you think PNH patients should stay away from?
I don't think so. Admittedly, it's a very rare patient population, not to me, not to you guys, but there have certainly not been large numbers of PNH patients vaccinated to date.
Thank you. Are there any ongoing clinical trials for the vaccine efficiency and safety in immunocompromised patients?
Not specific to our group of patients that I'm aware of. Veronica?
There are on some immunocompromised patients. I mentioned the solid organ transplant case. I know there's a huge effort to try to do that in bone marrow transplant patients, but not particularly in this patient population.
And I'll just mention the initiative through the BMT-CTN. It's well done, but I will be honest, I'm worried that I'm not going to know how to interpret the results quite as well, simply because the vast majority of those patients are going to be autologous transplants for multiple myeloma, or if it's for heme malignancies, as many lymphomas and leukemias as MDS, and certainly probably not many aplastic anemia patients. So I think it's going to be quite, challenging to extrapolate the results to us.
Thank you. This question reads, my MDS has progressed to AML. Do you think it is advisable for me to get the vaccine when my hemoglobin and platelets require at least weekly transfusions? Also, my neutrophils stay consistently below 0.6. I am not currently undergoing chemo because of my low counts.
This may be one where it's best to ask your treating oncologist. We, for example, are actually not actively, I know you're not getting treatment, but for example, our leukemia patients right now, we are not actively giving the shot when they're in the throes of the early phases of their disease. And if you've just evolved, I would really talk about it with your treating doctor.
Thank you. This question is, I'm due to start my next session of Vidasa for MDS 6 days after my scheduled vaccination. Could this be a problem?
No, the timing sounds pretty good to me, actually. I like it when my patients get it like a week before.
Great, thank you. And I'm switching here to our next section here. We've got quite a few questions here. It says they are moving the second dose of the Pfizer vaccine to 16 weeks. Will this have an effect on efficiency?
Veronica, I didn't catch all that. Did you hear it?
For sure. Yeah. So the question was about delaying the second dose of the Pfizer 16 weeks later.
Yes.
So earlier I said that it can be given as far out as 6 weeks. If that's not possible, then as soon as possible, because it's a fairly new vaccine and the way the trials were done and the way that people are getting vaccinated for the most part is within that time frame. We don't know what will happen to those that get the second dose far out. There's some data that they may still respond pretty well, but we have to keep in mind that the vaccine protection after only 1 dose is actually quite low. So we really need that second shot. Regardless of when you get it, as soon as you can, go ahead and get it.
Thank you. Dr. DeZern, I think you may have answered this, but I'm going to ask it again. Is there a recommended timing for getting the vaccine relative to scheduled Ultomiris infusions for PNH?
So Ultomiris is a little bit different. Our conversation was about Soliris.
Correct.
And the short answer is no. Again, get it when you can get it. But what I've just been trying to make sure for my patients is that I monitor for any increase in hemolysis. If you get it possibly after the Ultomiris was dosed, I don't know, let's say 6 weeks ago, are you going to make it all the way to the 8 weeks without increased hemolysis? It looks like yes, but I don't. If you didn't feel well and you thought you were hemolyzing more, it would not hurt to check the labs before the 8-week interval.
Thank you. Is plane travel safe once vaccinated, and if you are wearing a mask and taking all the necessary precautions?
Oh, these are tricky. The travel questions are tricky. The short answer is, with all the caveats, it's probably okay, but if you don't have to travel, you probably shouldn't either.
Yeah, so not emergent travel, not urgent travel is still somewhat discouraged. So if you really have to, I guess with all the precautions, it would probably be okay, but I wouldn't call it necessarily safe.
What is the recommendation for younger patients who may not be eligible for a vaccine? Is there hope that the vaccines will be eligible for patients younger than 16?
Go ahead, Veronica.
Yeah, so it's probably safe. And right now, one of the vaccine trials is actually enrolling patients younger than 16. So we're really hopeful that that'll be available soon enough.
And in some states that happen to neighbor us, I have obviously a number of patients in their 20s and 30s who are post-transplant, and certain states allow that as an age exception. So it may be something to check with for your state.
Thank you. Typically, immunocompromised patients are suggested not to get vaccines that have a live virus. How does that make the Johnson & Johnson okay for patients to receive that vaccine?
So I'm just going to clarify, that's not a live COVID vaccine. It's a vector vaccine, and the particular vector that the Johnson & Johnson or Janssen vaccine uses is a non-replicating vector, meaning that although it has a virus in it, it does not cause infection and does not replicate in you. So it's completely fine to get that particular vaccine. Thank you.
This question is regarding having an infection, such as this spouse is asking the question saying that they think that her husband has pneumonia. The question is, should he or should he not receive the vaccine? And if he does, what could be the consequences? So we were just talking about some contraindications to vaccination, and an active infection is a big one. So I would delay until you fully recover from that particular pneumonia. The consequence, I mean, you'll have the side effects on top of how poorly you're feeling already, but at the same time, and like I said before, I'm speaking in very simple terms, but your body defenses are sort of distracted from that pneumonia, so your vaccine response may not be ideal. So I would delay until you fully recover from any kind of infection, not only pneumonia. Thank you. This question comes from a patient who was diagnosed with severe aplastic anemia, which was triggered by severe viral hepatitis. Would the vaccine present a risk for relapse because the individual patient has a history of a virus causing their bone marrow failure? Then this is from a non-transplant patient.
So the association of autoimmune hepatitis and aplastic anemia has actually long been known and very well described, but I would not make the leap that vaccination against the virus would cause a relapse of the aplastic anemia. I would feel comfortable in that situation suggesting vaccination was very reasonable.
Thank you. This question reads, I've heard it is okay or better to get Johnson & Johnson after Moderna or Pfizer if you've had problems with the first. Would this be your recommendation? So I think what they're asking is if they had a reaction with the first dose of Moderna or Pfizer, should they go ahead and get the Johnson & Johnson and not get the second dose of either Moderna or Pfizer?
So it really depends on what kind of reaction. If we're talking about an allergic reaction, then you really have to look at what particular component of the vaccine you reacted to. Most of the allergic reactions are triggered by substances that are within the vaccine and not necessarily from the vaccine itself, if that makes sense. So a vaccine has multiple different components, and in order to be in liquid formulation and in order for us to be able to put it intramuscularly, it needs to have a lot of other solvents on it, right? And most people will react to those. So it really depends on what kind of reaction. If you had a true allergic reaction, both the Moderna and the Pfizer-BioNTech vaccine have different components. So it would be important to know exactly what you were allergic to. If that's not possible, then none of the messenger RNA vaccines would be safe. And so I wouldn't do either the Pfizer or the Moderna. The problem with the Janssen vaccine is if we don't know what you reacted to, the proteins that are produced could be similar, and so you might have a reaction to the Janssen too. So it would be very important. It would be very important to first of all know what the reaction was, what you reacted to, and then talk to your doctors to see which one would be safe to get next, if any of them.
Thank you. Should patients be tested for COVID before getting vaccinated?
No. Like I said a little earlier, even if you test positive, even if you had the disease before, you have to get vaccinated. So regardless of what that test shows, you still need a vaccine.
Thank you. Does a very low risk MDS patient who's already had both vaccines, the Moderna vaccines, have a higher propensity to become infected if they return to the gym than someone else who does not have MDS? Is it safe to swim without sharing a lane, use cardio or strength equipment if it is cleaned in between users?
So I don't think the risk there is related to the low or very low risk MDS. And it's great that both Moderna vaccines have been given. So I don't think the risk is any greater than the general population there, but we're still not fully recommending that the general population goes back into the gym either. So I think it's a little bit of a calculated risk.
Thank you. With the new guidelines from the CDC that were recently put out, does this have a different effect for bone marrow failure patients?
I don't really think so. What do you think, Veronica?
It depends on which particular CDC update are we talking about. Because I know that there's one that came out recently where it said that if you were vaccinated, then it would be okay to have,
the group.
yeah, exactly, to have a group within the house without masks. So I'm not sure what we're referring to, if that's what we're referring to, because that was the most recent update, I would still encourage people that have any degree of immunosuppression to still take precautions in terms of masks and washing hands and keeping social distancing, regardless of the recommendations from the CDC. For the most part, will refer to immunocompetent people.
Thank you. This comes from a patient, an aplastic anemia and PNH patient, who is questionable whether they will receive the vaccine. My view is that I will continue to play COVID roulette post-vaccine. What are your arguments against this point, and why should I receive the vaccine?
I hear you about the COVID roulette. I think that that's a fair question because we're telling you to still take the same precautions, but having the added protection against severe COVID and death makes sense to me. And that would be my argument for getting vaccinated. Veronica may have an even more infectious disease oriented one.
Not only the fact that you'll be safe, but others around you will also feel safer. The fact that you get the vaccine doesn't mean that you're not going to be contagious. You can still get the virus. You can still transmit the virus. You may not get sick from it. So it's not only for your own protection, but you have to think about people around you too.
Thank you. This question comes from an MDS patient who has received 2 doses of their vaccination and would like to know, is it now safe for them to visit with their grandchildren who are not vaccinated? Can they eat with them inside unmasked?
I had a nickel for every clinic patient who asked me this exact question. So the short answer is it depends on what the children have been doing, honestly. But I'm a huge believer that grandchildren are as therapeutic as any azacitidine I give for myelodysplastic syndrome. We just have to be very thoughtful. If the children are young and not really leaving the house and are sort of effectively quarantined anyway, then I think it's certainly fine to eat meals in the home like that. If these are high school students that are not socially distancing, having slumber parties, that's a much higher risk interaction. So it really depends on what the children are doing, a little bit less what you're doing, because you've done all your good stuff and are vaccinated, which is great.
Thank you. Do we know if the AstraZeneca vaccine will pose an increased risk for thrombosis in patients?
It's a concern, but COVID is also a risk for thrombosis. So I think it's a, thrombotic risk is we could spend a whole nother hour discussing that in general hematology, but it's to me not a reason not to get it. It's to survey for symptoms that could be a thrombosis post-vaccination. Is that fair, Veronica?
Absolutely.
Thank you. For PNH patients who are already at risk for thrombosis, is there any type of special monitoring that should be done for them once they start receiving the vaccine?
Not really. It's the same clinical symptoms you would monitor for any sort of clot in PNH. PNH patients are more prone to intra-abdominal clotting. So certainly if you felt you gained a whole bunch of fluid weight really quickly or had pain over your liver, which is in the upper right quadrant, or a swelling that was asymmetric anywhere in a limb, those are the general signs of thrombosis in all people, not just PNH people. Just be mindful of those.
Thank you. And this question comes from a CMML patient. They're on watch and wait, no medications and no treatments. Do you think it is safe for them to be vaccinated? And would there be any different type of efficiency with the vaccination?
Absolutely think that would be safe. Those are great patients to receive the vaccine.
Great, thank you. And this is for clarification, Dr. DeZern, you answered this. The question was, should a BMT patient who are getting IVIG and ECP not get the vaccine?
I do think that you should speak to your direct physician, though I'm being candid. I have several patients like that who I have chosen not to vaccinate because I do not believe they will respond. They both happen to be getting ECP 3 times a week, though, in addition to the IVIG.
Thank you. So this question reads, since immunocompromised can shred the virus for longer periods of time, and since the vaccine may not be effective for immunocompromised patients, does that mean that vaccinated immunocompromised patients are more likely to be super spreaders of the virus?
So super spreaders is a strong word, is what I would say. Super spread refers to when we have a big event and there was an index person that was positive, and in a gathering of 1,000 people, all of them got were in contact with that particular person and at risk. Whether they would be a long-term spreader, I would think that would be a better term for it, because yes, you can shed the virus for a much longer period of time. And the big concern that we have is that that virus could potentially evolve just like the flu virus does and change and mutate to the point that it may perhaps create not a new virus, but a new strain of that particular virus. And that's a big concern that we have with people that are shedding the virus for a long time. But I wouldn't call that a super spreader necessarily. If you are immunocompromised, you've had COVID and you've tested positive several times, and I would definitely recommend seeing an infectious diseases person that actually specializes in immunocompromised patients. There are some things that we can check and do for you in some experimental treatment that we could potentially get our hands on to help you perhaps decrease the chance and actually clear the virus. But the main concern that we would have is with that long-term shedding that the virus will change. Now, you will decrease your risks of spreading the virus if you wear masks and take all those precautions too.
Thank you. And our last question will be, it says, I realize that the best vaccine is the one that you can get, but here I can choose between Pfizer and Moderna. Is there any reason to favor one over the other for an aplastic anemia patient, perhaps due to the much lower antigen content of Pfizer?
I don't really think so. It might depend on your schedule, if you can go back in 3 weeks or 4 weeks more easily, honestly, if you really have a choice.
Agreed.
Great. Well, thank you both so much. And Alice, I'll turn it over to you.
Thank you, Dr. DeZern and Dr. Dioverti, for sharing your time and expertise with us, especially during this very challenging time. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. AAMD-SIF will continue to provide timely updates about COVID-19 and answer your questions as quickly as possible. By registering for this webinar today, you'll receive email announcements from AAMD-SIF regarding upcoming webinars and any new information posted on our website. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMD-SIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMD-SIF Medical Advisory Board and team are here to help you and your family as we have for the past 37 years. This concludes today's program.